Hello everyone. Today we will study the musculoskeletal anatomy of the lower limb, focusing on the muscles and nerves involved in movement. Let's start with a quick question. A 44-year-old office worker presents with difficulty walking and maintaining balance on her left leg following a car accident.
On physical examination, there is atrophy of the right gluteal region and a positive Trendelenburg sign on the right side. MRI shows no structural abnormalities, but electromyography indicates reduced activity in the involved muscles.
Which of the following actions of the hip are most likely compromised in this case as a result of nerve injury?
A. Abduction and external rotation. B. Abduction and internal rotation. C. Adduction and external rotation. D. Adduction and internal rotation. E. Extension and external rotation.
Think about your answers and we will revisit this later. Today, we are diving deep into the muscles of the hip and thigh as well as the associated nerves. The thigh region is divided into three fascial compartments: the anterior compartment, posterior compartment, and the medial compartment. This classification helps in understanding the functional anatomy of the thigh. Notice the muscles of each compartment and their respective nerve supplies. The anterior compartment is supplied by the femoral nerve, the posterior compartment by the sciatic nerve, the medial compartment by the obturator and sciatic nerves. The anterior compartment is primarily involved in flexion, the posterior muscles involved in extension, and the medial in adduction. Here is an image showing the various muscles. Now look at the muscles of the gluteal region, which are divided into a superficial group and a deep group. The superficial muscles involve the gluteus maximus, medius, and minimus, and the tensor fascia lata, whereas the deep muscles involve the gemelli, the piriformis, quadratus femoris, and obturator internus. These are also involved in hip movement. Here is a table summarizing the actions of the hip along with respective muscles and their associated nerves. Notice that flexion is primarily carried out by muscles supplied by the femoral nerve and the superior gluteal nerve, extension by the sciatic nerve and the inferior gluteal nerve, adduction by the obturator nerve and the sciatic nerve, abduction and internal rotation by the superior gluteal nerve, and external rotation by a diverse muscle group. Now let's take a look at the nerves of the lower limb. This table provides an overview of each nerve and the areas it innervates. It is important to know the nerve roots of each nerve as well. First, let's look into the superficial nerves. These include the iliohypogastric nerve, genitofemoral, and the lateral cutaneous nerve of the thigh. Notice the mode of injury of each. The iliohypogastric nerve injury is usually due to a surgical trauma. An injury to the genitofemoral and the ilioinguinal nerve usually takes place during herniorrhaphy, and an injury to the lateral cutaneous nerve of thigh is usually due to tight clothing or compression. Notice the term myalgia paresthetica as well. Here are some of the regions which are involved in sensory loss and affected by the respective nerves being injured. Next, we have the femoral nerve, the sciatic nerve, and the obturator nerve. Each of these has a unique mode of injury. Go over this table along with the respective clinical findings carefully. There is a loss of knee reflex in femoral nerve injury. Next, we have the superior gluteal, inferior gluteal nerve, and the pudendal nerve. I will be discussing the superior gluteal and inferior gluteal nerve injuries. The superior gluteal nerve supplies the gluteus medius, minimus, tensor fascia lata, and is responsible for internal rotation and abduction of the hip. The mode of injury is usually due to a hip surgery, trauma to the hip, intramuscular injection in the superior medial quadrant of the gluteal region, and the clinical findings include a Trendelenburg sign, which shows a pelvic drop on the opposite side to the injury, and there is difficulty in hip abduction. An injury to the inferior gluteal nerve paralyzes the gluteus maximus. This can result from trauma, hip surgery, and posterior hip dislocation. This causes a weakness in the hip extension, difficulty in standing from a seated position, and climbing stairs. Pudendal nerve injury can occur during childbirth, and pudendal nerve blocks are usually given in the ischial spine area. Understanding these muscles and nerves is crucial in clinical scenarios. Now let's revisit our initial question. So a 44-year-old office worker presents with difficulty walking and maintaining balance. There is atrophy of the right gluteal region and a Trendelenburg sign on the right side. The muscles involved in this case would be the gluteus medius and minimus, which are supplied by the superior gluteal nerve. As a result, the actions which will be compromised include abduction and internal rotation. Feel free to go over the answer explanations. Here is the key point. Thank you for your attention. If you found this presentation helpful, please like, subscribe, and share. See you next time.